Hello everyone, and in this video we'll be discussing a new topic, that is drugs for peptic ulcer disease, a very common disease. So whenever we think of peptic ulcer disease, we think of two important things, that is the gastric ulcer and duodenal ulcer. Very common, and it starts like gastritis, duodenitis, and it will end up with gastric ulcer and duodenal ulcer. So let us discuss what are the drugs for the peptic ulcer disease. So two important ulcer, the gastric ulcer, and one more is the duodenal ulcer. So usually not everybody have the ulcer or gastritis, but only few people will have this problem. What is the reason? The reason is simple, because the nature has given a balance between the acid and the protection. The protection is the barrier, that is a thick mucosal barrier. So whenever there is an imbalance between these two, then there is a chance of HCl causing gastritis, and that will lead to the ulcer. So the main aim of treating a peptic ulcer disease is to do this: decrease the HCl production. And one more bacteria which is a culprit for gastritis is H. pylori, that is called Helicobacter pylori. So we need to eradicate this. So H. pylori should be eradicated. Another important thing is you have to increase the secretion of bicarbonate, which will neutralize the acid, and increase the mucus, and also you can increase the mucosal blood flow. Mucosal blood flow. So please remember, the thing what we need to do is decrease HCl, eradicate H. pylori, and you have to increase the defensive factor, that is bicarbonates, mucus, and mucosal blood flow. So this is our goal. Let us achieve our goal by discussing the drugs. How do we do that? So we will correlate the pathophysiology of this. Now you should tell me, what is the cell which secretes HCl? So we all know that the cell which secretes HCl is the parietal cell. So this is the parietal cell, what I am writing. Parietal cell is the one which secretes HCl. Now this parietal cell has a pump, and the pump will throw out H plus out, and it takes in potassium inside. So this is also called by the name H plus K plus ATPase pump. Since it is throwing H plus out, H plus is also called as proton. So these are also called as the proton pumps. So these are called the proton pumps. Now along with H plus, there is arrival of chloride, and the H plus and chloride will form HCl. So that is how the HCl is produced. Now once I know how the HCl is produced, there are certain stimulus which will increase the HCl production, that is by activating the receptor called H2. There is a autocoid called histamine which can increase HCl production. Another important one which can increase the HCl production is acetylcholine. The acetylcholine, by acting through M1 receptor, it can also increase the HCl production. There is gastrin, which can act through a receptor called CCK1, cholecystokinin 1. Please remember, all these three, what I am marking, they all are going to increase the pump activity, and thereby they increase HCl production. Number 1, histamine. Number 2, acetylcholine. Number 3, gastrin. They increase HCl production. But who is the only opposition for this? That is the prostaglandin. So prostaglandin, we have the subtype E2, E1. So these prostaglandins are going to block the HCl production. Not only that, they increase the bicarbonate, they increase the mucus, and they increase the mucosal blood flow. So they are the protection which is given by the nature. Now you all know that we prescribe NSAIDs, that is analgesics, to the patients. And NSAIDs, they inhibit the prostaglandins. So that is the reason when we use NSAIDs, they block prostaglandin, there is a chance of gastritis that will lead to NSAID-induced peptic ulcer disease. Right. Another important aspect is a bacteria which is seen, which is also known to cause gastritis, and you know the name, and that is called H. pylori. H. pylori can induce gastritis. Now, suppose the HCl is increased. What happens when the HCl is increased? It causes gastritis. In the duodenum, it can cause duodenitis. And if that continues, it will lead to ulcer. So we get an ulcer like this. So it is called peptic ulcer disease. So this is the pathophysiology what we understood. Now, where do I target? What the drugs should I use? So you pause the video and just analyze where we can block these things. So number one, what I can do is block the proton pumps. So block, I'll write it as hashtag. So block it. Or block the histamine receptor, H2 blockers. So number one is this. Then number two, block H2. Number three, you block the muscarinic receptor. Number four, you block the cholecystokine receptor. But number five, we should not block. We have to increase the prostaglandins. Number six, you have to eradicate H. pylori, kill it and eradicate it. Number seven, what you can do is you can use certain drugs called antacids. So antacids are the drugs which neutralize the acid. Then what we have is peptic ulcer disease. Number 8 target, what you can do is you can use ulcer protectives. So this is the pathophysiology, and you understood what are the drugs we use in peptic ulcer disease. I will repeat again. Number one is proton pump inhibitors, H2 blockers, anticholinergics, the blockers of cholecystokinin 1. Then prostaglandin you should stimulate, eradicate the H. pylori, and then neutralize the acid by antacids, and then give ulcer protectors. So these are the drugs what we have for managing peptic ulcer disease. So we'll go one by one and discuss them. Okay? Yeah. The first target what I need to discuss with you all, they are called as proton pump inhibitors. So these are called as proton pump inhibitors, and majority of you know these drugs already. The name is pantoprazole. Pantoprazole. They all end with prazoles. Then we have lansoprazole. Then omeprazole. If you add S, it becomes esomeprazole. Then we have a drug called rabeprazole. So these are the proton pump inhibitors. So we know the drugs. Now once we know the drugs, let us understand how the drug works. That is called mechanism of action. Please remember, these drugs inhibit the pump that is called H+, K+, ATPase pump. And that is inhibited. They will ask in the exam, is it reversible or irreversible? The inhibition of the pump, that is the enzyme, is irreversible. So the inhibit the pump, H+, K+, ATPase, irreversible. That is their mechanism of action. Moving on to the pharmacokinetics, what should I know? Pharmacokinetically, remember, these drugs are prodrugs. These are prodrugs. So they become active. Once they become active, then only they will inhibit this enzyme irreversible. Another exciting thing what I want to tell you about these drugs are they have a very shorter half-life, that is 1 to 2 hours. If they have half-life of 1 to 2 hours, do you think we have to give it every 2 hours to the patient? No, you know that we don't give it like that. We give it once, maximum twice a day. But why they are given one or twice a day, once or twice a day? Because they are longer acting. How come? Even though their half-life is 1 to 2 hours, they inhibit the enzyme irreversibly. Suppose I give a drug, proton pump inhibitor, they block the enzyme. Once they block the enzyme, to make one more enzyme, it takes 1 day. So until that, the pumps will be blocked and the pump will never come back. It has gone, the enzyme is gone. So it takes the time to come back, and again the pump should start working. So this type of action is called hit and run drugs. They are called as hit and run drugs. So you know that somebody hits a pedestrian and moves away. It takes seconds, but the sufferer has to suffer for a very long period. Same thing, here the drug will stay in the body for a very short period, but the enzyme inhibition is for longer period. That's why it is called hit and run drug. That is proton pump inhibitors. Point number 1, prodrugs. Point number 2, the half-life is very short, but they are longer acting. Even the half-life is very short, the drugs are longer acting. The reason is hit and run drugs. Number 3, remember these drugs are given as entry-coated tablets. These are given as entry-coated. Now, what is the reason why do we give it as entry-coated? The reason is simple. Suppose this is the stomach and the intestine like this. Suppose if I give the drug like that, without entry coating, what happens if the drug goes to the stomach? It is destroyed by the acid in the stomach. So to prevent acid destruction, we give the tablet as entry coated. This was asked as a question for you. Why the tablets are entry coated? To prevent acid destruction. To prevent acid destruction, it is given entry coated. So what happens if this is the tablet? We'll give a coating on this. We'll give a coating on this. So this tablet will not get opened in the stomach. When it goes to the intestine, then only it is released. The coating is released because of the alkaline pH in the intestine, and the drug is released, then gets absorbed. So point number 1, prodrug, half-life is 1 to 2 hours, and the drug is entry coated. Point number 4, what about the pharmacokinetics you need to understand is, should we take it before food or after food? Now usually it has to be taken 1 hour before food. Why do we give it 1 hour before food? Because they inhibit the active pumps. Now when the pumps are active, obviously the pumps are active when you start taking the food. So when you take the tablet, it has to be absorbed, distributed, then come to the site of action. It takes time. So it takes around 1 hour when you take it orally. So when you start eating, the pumps gets active. When the pumps are active, the drug will go and block it. That's the reason it has to be taken 1 hour before food. And also there is an interference with food. Food also decreases the absorption of PPS. So it is ideally taken 1 hour before food. Now there is a enzyme inhibition. Enzyme inhibition is seen with a drug by the name omeprazole. Omeprazole can cause enzyme inhibition. One common drug interaction they will ask in your exam, please note down. Can we use omeprazole and an antiplatelet drug called clopidogrel together? That is the commonly asked question in our exams. Can we use them together? Please remember, clopidogrel is a prodrug. You know what is a prodrug? Prodrug is inactive. After metabolism, it becomes active. So it will become active with the help of metabolism. Who will convert that? There is an enzyme called cytochrome 2C19. So this is the enzyme which will convert it. Now when I use clopidogrel, it will become active, no problem. But when I use omeprazole, omeprazole is an enzyme inhibitor. It inhibits this. Now you think and tell me, if I give omeprazole and clopidogrel together, what will happen? Clopidogrel will not become active. Patient will not have antiplatelet activity. So patient may have MI or stroke. So that's the reason these two drug combinations should not be used. Sir, is this interaction seen with other PPIs? No. It is only seen with omeprazole. Other PPIs you can use it, no problem. One more important aspect is the drug interaction I want to tell you here is, can we use PPI with iron? Remember, the iron absorption depends on acidic pH. Okay, so acidic pH is required for iron absorption. So when you use PPI, the PPIs will not make the pH acidic. They will try to increase the pH to alkaline environment. So when we give them together, there is decrease in iron absorption. So don't give them together. So this is the pharmacokinetic importance I just had to tell you about PPIs. Okay. So I understood the mechanism, I understood the drugs, I understood the pharmacokinetics. Then what should I know? I need to know, where do I use these drugs? Uses. Number one, obviously, we are going to use it in the disease which we are discussing, the peptic ulcer disease. Second important, we are going to use it in a condition called GERD. What do you mean by GERD? Gastroesophageal reflux disorder. So it's a problem where the acid comes to the esophagus because the esophageal sphincter is lax. That is, it's not working properly. Now, we also use them in one more condition that is called H. pylori eradication. So we use it in H. pylori eradication regimen. So peptic ulcer disease, GERD, H. pylori eradication. It is also the drug of choice for NSAID induced peptic ulcer disease. So whenever we prescribe NSAID, that is analgesic like diclofenac, aceclofenac, most of the physicians prescribe PPIs along with that to prevent gastritis and peptic ulcer disease. So the drug of choice for that is PPIs. Now another important condition where we use them is in a condition called Zollinger-Ellison syndrome. So Zollinger-Ellison syndrome is a condition where the gastrin is very high. It's a hypergastrinemia condition. You know that gastrin itself can increase the production of HCl. So these are the major conditions where we use PPI. Many a times we also use it as the pre-anesthetic medication. We use it as pre-anesthetic medication. And also, one more important point you need to understand EFG is we use it in bleeding peptic ulcer. What is the reason why do we use it in bleeding peptic ulcer is a question. I'll explain it here. Now this is the stomach and the intestine. Let us assume that there is ulcer and starts bleeding. So the blood starts oozing out. So what is the defense mechanism by the body? To form clot. So it will form a clot to prevent the bleeding peptic ulcer. But because the acid stomach pH is there, acid will not allow the clot to stabilize. So acid will dissolve the clot. Since already acid is very high, the clot is not stabilized, so bleeding continues. So what should I do? Give high dose of PPIs. So high dose PPIs, what do? They decrease the acid in the stomach, and that will allow the clot to stabilize. So that will stabilize the clot. And once you stabilize the clot, obviously what happens? The bleeding decreases. There is decrease in bleeding. So that's why they are used in bleeding gastric ulcer, peptic ulcer diseases. We can use it. Right, guys? So just go through these uses. Okay. Then once I am done with that, I'll be telling you the adverse effect, the major adverse effect, what you need to understand here. Now, why the nature has given us acid in the stomach? Number one, to digest. Number two is to kill the bacteria. Now, when you elevate the pH, increase the pH in the stomach, you are moving towards alkalinity. There is two problems. What are the two problems? Number one, the bacteria can grow. So that will lead to the infection, that is pseudomembranous colitis. That is one of the common problem. And can you guess what is the bacteria which causes that? It is called Clostridium difficile. The second problem what we can see is there is a chance of pneumonia and there is a chance of spontaneous bacterial peritonitis. So the infection increases. And along with that, there is deficiency of certain elements. For example, there is decrease in calcium, and you know that it will lead to osteoporosis. There is decrease in iron. I just told you the interaction of iron. So what happens if iron decreases? Patient may go for anemia. It can also decrease the absorption of B12, so that will also lead to anemia. And also recently they have found out that it can decrease the magnesium level. So this is the reason when we use PPIs for a very long time, this is the problem. They decrease calcium, osteoporosis, they decrease iron, B12, anemia, and they can decrease magnesium. Now, certain times, very rarely, they can cause a problem called atrophic gastritis. They can cause atrophic gastritis. And in the animals, for example, in the rats, they have shown to produce teratoma. So this is one of the study they have shown, it has shown to produce teratoma. Should I be worried about that? No need. Then recently the government has given a warning to the patients that it can cause acute kidney injuries. Acute kidney injury. So this is the warning given by the government, because patients use a drug without taking the advice of the doctor. So this is a major problem what we see with PPAs. Okay? Yeah. Once we are done with the first target, that is proton pump inhibitors, let us move on to the second target. The second targets are the H2 blockers. H2 blockers. So the first H2 blocker that came to the market is called cimetidine. Cimetidine had some limitations. Problem is it was short acting. It was short acting, but it has anti-androgen property. So it had anti-androgen property. So what happens if you give it to a male patient start complaining of loss of libido. And one more problem that happened is gynecomastia. Patients complains of gynecomastia because of anti-androgen effect. So that's the reason this drug is outdated. We don't use it nowadays. So what we use commonly is a drug by the name ranitidine. So ranitidine is longer acting and it has no anti-androgen effect. That is the advantage. Other drugs are loxatidine, then famotidine. These are the H2 blockers. Since the most efficacious drugs are PPAs, H2 blockers are not commonly used nowadays. But the advantage of them, H2 blockers, is they are shown to decrease the basal acid output better. They decrease basal acid output better. What do you mean by basal acid output? Suppose you take a meal, then the acid gets secreted, that is called stimulated acid secretion. Now in between the meals, there is some acid that is secreted, that is called basal acid secretion. For example, in the night, you have taken the dinner, morning you will have the breakfast, in between the acid gets secreted, that is called basal acid secretion, that is decreased by H2 blockers. That's the only advantage. Otherwise, the best drugs for peptic ulcer disease, the most efficacious drugs for peptic ulcer disease still today is proton pump inhibitors. Now moving on to the third important target, blocking the muscarinic receptor. They are also called as anticholinergic drugs. So the anticholinergic drug what are used are pyrazipine. They end with Z-pine. And one more drug is called tilenzepine. So please remember they end with Z-pine. So usually I think most of you have not prescribed this drug, but this is asked for exam. Recently they had asked this question, where do you use pyrazipine in gastritis? Number 4, What about blocking cholecystokinin 1? Now still the drug is not being discovered. So we are in the search of the drug. It's not being discovered now. What about the fifth one? What about the fifth one? The fifth one is stimulate prostaglandin. So we have a drug by the name misoprostol. The drug name is misoprostol and it is a PGE1 analog. So misoprostol is called as prostaglandin E1 analog. I told you what does it do. It increases mucus, it increases bicarbonate. Now misoprostol is considered as most specific drug for it's the most specific drug for NSAID induced peptic ulcer disease. Now why it is called most specific? The reason is when you give NSAID, what happens? Prostaglandin decreases. That's why gastritis. So what is the specific therapy? Give prostaglandins. So if they ask this sentence, then the answer should be misoprostol. But if they ask you drug of choice for NSAID induced peptic ulcer disease, the answer should be PPAs. Please keep that. Now where do you don't use the drug? That is contraindication. If I write C/I, it is contraindicated in pregnancy. Now why it is contraindicated in pregnancy? Because it's a uterine stimulant. It can abort the baby. So if a pregnant lady comes with peptic ulcer disease, don't ever give misoprostol. You are treating peptic ulcer disease, but you are aborting the baby. Second, it should not be used in inflammatory bowel disease. Inflammatory bowel disease. Now, why we should not use it in inflammatory bowel disease? Yes, you know that prostaglandins are inflammatory mediators, so we should not use them there. So we're done with target number 5. Let me come to the target number 6. Target number 6 is H. pylori eradication. H. pylori eradication. Now, why should I eradicate a small bacteria called H. pylori? Number 1, the H. pylori has shown to produce gastritis. Not only that, it has found to produce a lymphoma called Mant lymphoma. These are 2 reasons why we should eradicate this. How do you do that? To eradicate that, most of the regimens use proton pump inhibitors, that is PPAs. Along with that, we add other drugs, for example, amoxicillin, then bismuth subcitrate. It is called bismuth subcitrate. Then we have clarithromycin, then tetracycline. One more drug is metronidazole. So along with PPAs, we have other options also: amoxicillin, then bismuth, clarithromycin, tetracycline, and metronidazole. Please remember, you have a mnemonic for this. I will give a mnemonic. The mnemonic is ABC and TM. So you remember like this. The drugs are ABC, TM for trademark. So if you remember, whatever other option they give in the exam, you can easily rule out that. ABC, TM. Okay, so I will discuss about a drug called colloid bismuth subcitrate. The drug has 2 important properties. One is anti-H. pylori property. How? The reason is it has shown to dislodge H. pylori from its attachment to the gastric epithelium. So it dislodges H. pylori from the gastric epithelium and thereby it throws it away. And also the drug has shown to have ulcer protective effect. So it can protect ulcer. But the adverse effect, since it has bismuth, it can cause the blackening of tongue. So the tongue may become black, and also it can cause osteodystrophy. It can cause osteodystrophy, but it is contraindicated in renal failure, which may lead to bismuth toxicity. So renal failure can lead to bismuth toxicity, so don't give it a renal failure. So I was telling you the drugs for H. pylori, the ABC trademark with PPI. The question is, should we use all the drugs to the patient? No. There are regimens for this. So let me explain in this slide the H. pylori eradication regimen for you. H. pylori eradication regimens. So the first one is called the triple drug regimen. Triple drug regimen. So remember, in triple drug regimen, we use the regimen called OCM. So O for any PPI, proton pump inhibitors. For example, you can use omeprazole, lansoprazole. Usually the preferred PPI nowadays is lansoprazole for H. pylori eradication. Then C stands for the clarithromycin. M stands for the metronidazole. The metronidazole. So O for any PPI, C for clarithromycin, M for metronidazole. So they are given twice daily. How many days should be given twice daily? 14 days, that is 2 weeks. That is one regimen. One more regimen I just want to tell you is OCA. O for any PPI, C for the clarithromycin, C for clarithromycin, and A for amox. So here also we give it twice daily for 14 days. So twice daily, and it is given for 14 days. So these are the triple drug regimen. Only we give 3 drugs. But sometimes even with this, it may not get cured. So we use a regimen called quadruple drug regimen. So what does quadruple regimen contains? Quadruple regimen contains O, B, T, M. O for the PPI, proton pump inhibitor, and B for bismuth. And T stands for the tetracyclines. It is the tetracycline. And M, you all know that it is metronidazole. So this is the regimen we use, quadruple. So this is the eradication regimen what we use for H. pylori. So once we are done with that, let us move to the next target, the 7th target, and they are called as antacids. The name itself is telling you they will have antagonist effect on acids. So there was an antacid called systemic antacid. The systemic antacid is called sodium bicarbonate. So what happens when you use sodium bicarbonate as an antacid? It will combine with HCl. So what you get? You get sodium chloride, that is salt. You get water, and you get carbon dioxide. So because of this carbon dioxide, patient will have the burping effect. Okay. But the problem with systemic antacid is when you give sodium bicarbonate, there is a chance of alkalosis to the patient. Since it is giving sodium and chloride, there is a chance that there is edema. So it is not used in a patient with hypertension or CHF because it will retain sodium and chloride. Since it generates carbon dioxide, the problem is here. This is the stomach. This is the intestine. Sometimes what happens, there is an ulcer in the stomach. Once the patient takes sodium bicarbonate, that is NaHCO3, the carbon dioxide release will put a pressure everywhere. So carbon dioxide will put a pressure everywhere, and if the ulcer is about to perforate, there is a chance of ulcer perforation. So these are the risks which are associated with sodium bicarbonate. That is why this is not used nowadays. So then what is used? Recently we have come up with non-systemic antacids. Non-systemic antacids. So what are those? Name is magnesium hydroxide. So I will give an example. If I magnesium hydroxide combine with HCl, what do you get? You will get magnesium chloride plus water. So there is no chance of carbon dioxide, so there is no risk of ulcer perforation. One more drug is called aluminium hydroxide. It is written as AlOH3. Then we have a drug called megaldrate. So these are the non-systemic antacids what we use. Right. So problem here is magnesium hydroxide. When I use it, patient will complain of diarrhea. If I use aluminium hydroxide for the patient, he will complain of constipation. The patient will complain of constipation. So you should decide and tell me which one should I give to the patient. Should I give magnesium or aluminium? So that's the reason why we combine both of them. So when we combine both of them, the advantage is there is decrease in adverse effect. So the adverse effect will decrease, and also the dose of the drugs decrease. So when you decrease the dose of the drugs, there is a decrease in toxicity also. So that's why magnesium and aluminium are given together. Remember, the antacids are the fastest acting drugs in peptic ulcer disease. So they will act quickly, fastest acting. Sir, when they are fastest acting, why are they not so popular? The reason they are not popular is what happens in the stomach. In the stomach there is acid. When we take antacid, they will neutralize only that. Again the fresh acid comes to the picture and you have to take it again, antacids. So you have to use it multiple times in a day, 4 to 5, 6 times. So the efficacy is not that much good. Even though they are faster acting, their efficacy is not good. Now when to administer the antacids? Is it before food ideally or after food? Ideally you should be taken 1 hour and 3 hours after meal. So that is the ideal time to take antacids, because most of them, when I ask in the exam, when I ask in the classes, I tell that it is taken before food. But ideally, you can take any time, but ideal time is after the meal. Now remember, when you are using antacid with other drugs, suppose a patient is taking a drug by the name digoxin and patient has to take antacids. So what is the gap? The gap between the drug and antacid should be 2 hours gap. So if you don't do that, the absorption of digoxin gets interfered. These are the practical issues which they will ask in the exams. So antacids are faster acting. They are taken after meal, that is 1 hour and 3 hours after meal. And when you are using with that drug, there should be a gap of 2 hours. This is the important aspect. Okay. Now we are done with number 7 target. Let us move to the 8th target. The 8th target, the drugs are called ulcer protectives. Ulcer protective drug, already I told you there is a drug which can protect that is colloid bismuth substrate. Now problem in ulcer is, suppose this is the ulcer, in surgery, ulcer, it's a break in the epithelium. Now if there is a wound outside, what we can do, we can put a bandage. Why do you put a bandage? So that the external environment will not disturb the healing process. But if there is a ulcer in the stomach or duodenum, the HCl keeps on coming and starts irritating it, and the ulcer will not heal. So what should we do? We should put a bandage. Can we swallow the bandage? No. So what we do is we use a drug by the name sucralfate. So sucralfate, what happens when we give at the pH less than 4, at the pH less than 4, it polymerizes. It polymerizes and it forms a coating on the ulcer. So if this is the sucralfate, I'll just show you. So sucralfate will form a coating like this on this. So it will polymerize and make a coating like this. So after it coats the ulcer will start healing. So that's why it is called ulcer protective. The name is sucralfate. Now same thing happens with sucralfate. Suppose you are using sucralfate with a drug called phenytoin. I will take the next slide and explain to you. Suppose a patient is taking phenytoin and sucralfate. Can he take them together? No. What is the reason? Can he take them together? No. What is the reason for that? Let me write the stomach for you. This is the stomach. Now suppose the patient has taken sucralfate. Now when the patient takes sucralfate, what happens? Sucralfate will coat the stomach like this. Now when it coats the stomach like this, when a patient takes phenytoin, that is P, phenytoin will not get absorbed because the coating will not allow the phenytoin to get absorbed. So there is hindrance of absorption. So that's the reason there should be a gap of 2 hours. 2 hours gap should be given. There's one more question that was asked in the recent exam. Phenytoin, sucralfate, what is the time gap? 120 minutes, that is 2 hours gap. Another important question I want to ask you all, can I give antacids plus sucralfate together? Can I give antacids and sucralfate together? I just pause the video and just try to analyze the answer for this. Now you know that sucralfate will polymerize at a pH less than 4 only. But when I add antacids, the pH will get elevated. There is increase in pH. And if the pH increases, the sucralfate will not polymerize and it will not produce the effect. So this combination is not used. So we call it as irrational combination. A repeatedly asked question. Don't combine antacid with sucralfate. Another important aspect, apart from this peptic ulcer disease, do we use sucralfate anywhere else? Yes. Sucralfate binds phosphate in the gut. Sucralfate binds phosphate in the gut. So why should I use it? I can use it to treat a condition called hyperphosphatemia also. I can use it to treat hyperphosphatemia. It is contraindicated in renal failure patients. The reason why? Because sucralfate is made up of aluminum. It has aluminum in its structure. So it can lead to aluminum toxicity. So don't give it in a patient with renal failure. So that is about sucralfate, the ulcer healing drug. And one more is colloid bismuth subcitrate. So sometimes we use a local anesthetic in peptic ulcer disease. What is the name of that local anesthetic? The name of that local anesthetic is oxytocin. So that is also used. And there is a drug called ulcer healing. The ulcer healing drug is called carbenoxolone sodium. So these are the drugs what we use for peptic ulcer disease. So let me give a quick review. The drugs for peptic ulcer disease, the major aim is to decrease HCl and to kill the H. pylori and eradicate it. The second major aim is to increase the mucus and increase the mucus blood flow and bicarbonate. So the only thing which protects us is prostaglandin, and there is a cell called parietal cell which secretes HCl. So we have PPIs. Number 2, we have H2 blocker, anticholinergic drug, pyrazipine, tilenzapine. Then we have the misoprostol. Then we have the H. pylori eradication regimens. Then we have antacids, systemic and non-systemic. And then ulcer protective, that is sucralfate. Most of your exam question is based on PPAs. They all end with prazoles and they inhibit an enzyme called H plus K plus ATPase irreversibly. They are shorter half-life, but they act for very long because they come under a category called hit and run. Why they are hit and run? Because they inhibit the enzyme irreversibly. And the drug of choice for NSAID-induced peptic ulcer disease, they are used in GERD, and also they are used in Zollinger-Ellison syndrome. So in this video, we have discussed what are the drugs used for peptic ulcer disease. Thank you all.